chairpersons, may I thank the organizers for giving me this opportunity to talk to you today. My title is the use of transesophageal echocardiography to minimize perioperative heart failure. Cardiac failure is the inability of the heart to produce a sufficient cardiac output which is able to provide the oxygen requirements of the body. More than 20% of patients have acute cardiovascular dysfunction in the perioperative period after cardiac surgery. This applies to non-cardiac surgery as well. Aggressively preserving heart function is a goal in managing these patients during the perioperative period. What that means, in other words, is that we have to provide the required oxygen delivery during the entire perioperative period. Oxygen delivery, as we know, is dependent on the cardiac index, which is the cardiac output divided by the surface area, into the oxygen carried by the hemoglobin and the dissolved oxygen. So the cardiac output or the cardiac index becomes the main determinant of the oxygen delivery. Remember this Frank-Starling curve. It shows the relationship between the volume and the output. And as you can see, when you keep on increasing the volume, the output will increase up to a certain level and then plateaus out. And then further, if you increase the volume further, it will drop. And the position of the Frank-Starling curve will depend on the contractile state of each heart. If the heart is sympathetically stimulated, such as with exercise, it will be shifted to the left and high, where with a smaller volume, you can increase the output to a certain extent. Whereas if the heart is in failure, it is shifted to the right, and therefore you will need a larger volume to increase the output, and that output will be low or limited. Whereas in cardiogenic shock, even this is not possible. Therefore, cardiac failure in the preoperative period can be due to pre-existing cardiac failure, which decompensates during the perioperative period. If too much fluid is given, where you shift the patient to the plateau part of the Frank-Starling curve, an acute ischemic event, which can happen perioperative like an acute coronary, or following heart surgery, right ventricular dysfunction, or severe systemic vasodilatory shock. So cardiac failure during the perioperative period is commonly due to these reasons. Now the cardiac index or the cardiac output is also dependent on the volume, the contractility of the myocardium, and the afterload or the resistance against which the heart pumps. Now with transesophageal echocardiography, the advantage is we can monitor and measure all these, not only the cardiac output, but also the factors which affect the cardiac output, such as the volume, the contractility, and the afterload. So in prevention of cardiac failure during the perioperative period, first of all, we need to diagnose or assess the heart function as at that moment, and we need to take appropriate actions to prevent deterioration of heart function and to preserve the oxygen delivery as to the required amount. So pre-existing heart failure. Now, my practice, soon after induction of anesthesia, I do transesophageal echocardiography because we know the pre-existing echocardiographic value. So soon after induction of anesthesia, I perform echocardiography to confirm that the ejection fraction is low, and this is continued during the entire intraoperative period. And if the ejection fraction is less than 30%, I electively start an inotrope. My choice here is milrinone because of the following reasons. It is inotropic, it has vasodilatory actions which reduces the afterload. However, we may need a vasopressor in conjunction to maintain perfusion pressure. It does not cause tachycardia unlike dobutamine. It improves diastolic function, improves splanchnic perfusion, prevents coronary spasm, and it increases cardiac index and therefore oxygen delivery. Also, with long-standing heart failure, such as with patients who come into surgery with pre-existing heart failure, there is downregulation of beta-1 receptors. So therefore, an inotrope which acts on a different receptor, such as milrinone, may be more useful. And it has also been used with success in weaning off patients with low ejection fraction after cardiopulmonary bypass. I use milrinone starting immediately prior to induction in patients with ejection fraction of less than 30%. A standard dose of 0.5 mics per kilogram per minute is used during the entire period. And noradrenaline may be used to maintain the mean arterial pressure in the region of 70. In the post-operative period, I use 2 more vials of milrinone and then convert to dobutamine or adrenaline because of the risks associated with milrinone, such as arrhythmias and sudden deaths. There are reports that levosimendan has better results than milrinone. Unfortunately, I have no experience with that. This is an echocardiography soon after induction of a patient. You can see the hugely dilated left ventricle. This patient had an ejection fraction of only 23%. The next stage is to assess the volume status in order to optimize it during the perioperative period. Traditionally, and for many years, it has been the CVP or the wedge pressure which we have used for this purpose. These are termed static parameters, and it has been found that 50% of the time it is wrong. They are called static parameters because they are measured under a single loading condition. What it means is we get a CVP at a particular point of time where the volume at that moment gives us a pressure saying a CVP of this. It does not tell us whether that CVP is adequate or inadequate or the patient is overloaded. The same goes with the wedge pressure unless it is beyond 18. And it has been found that using the CVP and the wedge pressure to guide fluid therapy, that 50% of the time it has been withdrawn and it is not recommended to be used anymore. This may be because that the stroke volume depends not only on the volume but also on the ventricular compliance and the afterload. What is recommended now is to look at the collapsibility of the vena cava. The superior vena cava can be measured with transesophageal echocardiography and the inferior vena cava by ultrasound. The principle here is fairly simple. That is, when you are mechanically ventilating a patient, when the intrathoracic pressure goes up, if the superior vena cava does not hold sufficient volume to withstand that pressure, it will collapse. And during expiration, when the intrathoracic pressure falls, the vena cava will expand. So this collapsibility of the vena cava is deemed to be a measurement of the fluid status of the patient. And with transesophageal echocardiography, these are the first structures which come into view on insertion of the probe. It is at the high esophageal position, and once you identify the superior vena cava, you rotate the probe to 90 degrees and apply the M mode. This is what you see first. The big ring is the aorta. Next to that is the superior vena cava. This is rotated to 90 degrees and the M mode is applied. You can clearly see how the superior vena cava collapses and expands. So this is a patient who is not fluid loaded, who can be considered to be able to handle some more volume. But in this patient you can see there is no collapsibility of the superior vena cava. So we mustn't give fluid to this patient. Then another sign of an empty heart is the empty left ventricle with the characteristic kissing papillaries we show a view, where the two papillary muscles come together. So the next question is optimizing the volume. And the question we need to ask is, will giving volume increase the cardiac output of the patient? Because that is our aim. And we give fluid only if we can assess and say that giving a fluid challenge will increase the cardiac output. And these patients are termed fluid respondents. So fluid responsiveness can be assessed. If we go back to the first slide I showed, the Frank-Starling curve, the patient's heart should be functioning on the ascending part of the curve. Only then, if you give a volume load, will the output increase. To measure this, dynamic parameters are required. And to get the dynamic parameters, we depend on heart-lung interaction. Again, going back to the slide, this is what I said. For the volume to increase, the patient's heart should be functioning on the ascending part of the Frank-Starling curve. Now, dynamic parameters as opposed to the static parameters depends on the output at two different loading conditions. If you go back again to the previous slide, if you have two different volumes and if the output is different at those two volumes, then you know that the patient is on the ascending part of the curve. This is what is meant by the output at two different loading conditions. And for this, we depend on heart-lung interaction. And for this, the patient should be on mechanical ventilation. And with inspiration, the intrathoracic pressure rises. When the intrathoracic pressure rises, the venous return falls. Now, going back to the Frank-Starling curve, if the venous return falls, that means the output should fall. Then during expiration, the intrathoracic pressure falls, therefore the venous return increases. And if the venous return increases, therefore the output should increase. So a patient should show this change in output in either the systolic blood pressure, stroke volume, or the pulse pressure variation. So we have 2 points on the curve, 2 loading conditions. And if we can measure this variation in the systolic blood pressure, stroke volume, and the pulse pressure, that will give us an indication that the patient is responding to fluid. So going through that again, by obtaining 2 points in the Frank-Starling curve during inspiration and expiration, we are able to identify in which position the patient's heart is on the Frank-Starling curve. And if this variation is shown, the patient is on the ascending part. If there is no variation, then the patient is on the plateau part. And to do this, we can use transesophageal echo or pulse contour analysis with some of the mechanical methods we have. Now, this is a patient on transesophageal echo. The probe is positioned just distal to the aortic valve. So the flow coming out of it is the stroke volume. And the peak velocity is easily seen. Now, the peak velocity can be taken as a surrogate of the stroke volume because we can assume that the aortic valve diameter remains constant. Or we can actually measure the area under the curve and get the stroke volume. But you can clearly see that there is variation in the peak velocity. So this is stroke volume variation. And if we give a fluid challenge to this patient, he should improve his output. Here, there is no variation in the stroke volume. So we must not give fluid to this patient. However, these dynamic parameters, to be assessed properly, several conditions have to be met. That is, the patient has to be mechanically ventilated, and there should not be any attempt at spontaneous breathing at the time of assessment. And the same heart-lung interactions which give us these dynamic parameters can cause problems in the interpretation as well. Several issues arise out of the respiratory system. The magnitude of the tidal volume. If the tidal volume is very, very large, artificially high, we will create an exaggerated rise in intrathoracic pressure, which will therefore cause an exaggerated response or a stroke volume variation, which may not be accurate. On the other hand, if the tidal volume is very small, it may not generate a sufficiently high intrathoracic pressure to create a change in the venous return. So De Baker and them have recommended that a tidal volume of 8 ml per kg has to be used at the time of measurement. Then another problem is PEEP. If PEEP is being applied, then the intrathoracic pressure is constantly high. Therefore, the stroke volume variation which we may get will again be exaggerated. But what is important is, as we know, when you sometimes apply PEEP, you get a drop in your blood pressure and a drop in your cardiac output. But along with this, if you see that there is a change in your stroke volume or the stroke volume variation, then you know by giving a fluid challenge, you can reverse the situation. Then the chest and lung compliance. Now the chest compliance is very poor. Then the generated intrathoracic pressure will be very high. And again, you will see an artificially exaggerated stroke volume variation. If the chest compliance is very good, on the other hand, the generated pressure may not be sufficient to create a change in the venous return. And this we see quite often in cardiac surgery with the chest open. So if you do not see stroke volume variation with the chest open, it does not necessarily mean that the patient is not volume responsive. You need to wait till the chest is closed to get a proper assessment. Lung compliance. We might not see this during the intraoperative period, but if there is a condition such as ARDS or pulmonary edema, the generated intraalveolar pressure may not get transmitted to the intrathoracic area. Therefore, we might not see again changes in venous return. However, clinically, the generated intraalveolar pressures are very high, and very often we use PEEP in these situations. It has been found that clinically it is not such an issue. Then the ventilator rate again may not be such a problem during the intraoperative period. If the ventilator rate is set very high, there may not be sufficient time for the venous return to adjust. Then there are issues arising from the heart. If the heart rate is very slow, the changes in venous return will be minimized. And if there are irregularities, the irregularities may account for the changes in left ventricular filling rather than changes in intrathoracic pressure. So at the time of measurement, the heart rate should be within normal limits and there should not be any irregularity. Ventricular function is very important, particularly the right ventricle. If the right ventricular function is impaired, then that means the left ventricular filling is affected. So you might see stroke volume variation in patients with right ventricular dysfunction. However, depending on that, if we give fluid to these patients, the right ventricle will dilate further. It will shift the interventricular septum to the left, further compromising left ventricular function and output. So you will worsen the situation. So it is very, very important that the right ventricle is assessed with transesophageal echocardiography before you give fluid. The left ventricle, of course, is not a problem. If it is failing, then on the Frank-Starling curve, we know that patient will not show stroke volume variation. Then the cardiac afterload. If the resistance is very high, again the changes in stroke volume variation will be reduced. Then the arterial compliance. What is meant here is the matching between the ventricular system and the arterial system. To get a proper output, the two systems need to be matched. This is the dilated right ventricle, and if you give further fluid to this patient, you are going to dilate that right ventricle further, shift that interventricular septum more to the left, further compromising the left ventricular cavity size. Now the afterload, traditionally again which we measure with the wedge pressure or pulse contour analysis, is just a number. Whereas with transesophageal echocardiography, we are able to know what to do with that afterload. Whether we need to use a vasoconstrictor or a vasodilator. One such measurement is what is called the afterload reserve. where you take the ratio between the pulse pressure variation from your monitor and the stroke volume variation from your echocardiography. And if the ratio is less than 1, then a vasoconstrictor is indicated to improve the oxygen delivery or a fluid challenge. If the pulse pressure variation is greater than 1, the patient needs a vasodilator. Then another such measurement is dynamic arterial elastance, which was just what I was telling you earlier. This is a measurement of the matching between the ventricular system and the arterial system. And here you measure the difference between the end systolic volume divided by the stroke volume. And again, so these two measurements we can easily get from transesophageal echocardiography. And if the ratio is again less than 1, a vasoconstrictor will help to improve the oxygen delivery. If it's more than 1, a vasodilator will help. Transesophageal echocardiography influences both the anesthetist and surgeon's therapeutic options perioperatively. So it is a very, very useful piece of equipment to have. This is where I come from, Sri Lanka. Thank you very much.